You're okay, Antra? We can go ahead?
Yeah, Antara, you can start the presentation.
Yes, yes.
Your topic for today is regional anesthesia for upper limb in pediatric cases. So
Yes,
go
sir.
ahead, Antara.
Yes. Good evening, everyone. Today we'll talk about regional anesthesia for upper limb in pediatric cases, presented by me, Dr. Antra, and moderated by Dr. Ankit sir and Dr. Kiran ma'am. So today So we have a 7-year-old male child, resident of Mumbai, weighing around 25 kgs. The child had a history of fall while playing, causing refracture of a right radius and ulna. So patient had a history of fall on the 19th of February, sustaining a fracture to the right radius and ulna, for which he underwent tense nailing under general anesthesia with face mask and a USG guided right axillary block. Patient again had a fall on 9th of March, sustaining a refracture at the same site at right radius and ulna. There was no history of any other trauma to head, chest, or abdomen. There was no other significant medical history. The birth history, the patient was full term, normal term delivery, and birth weight was 2.6 kgs. He was immunized till date, and milestones were achieved as per age. On history and examination, the general condition was fair. The vitals were stable and within normal limit. All the systemic examination was within normal limit. The spine, there was no abnormality detected, and on local anesthesia, there was no distal neurovascular deficit. The plan of action of the surgical team was removal of in situ TENS nails with re-nailing of the same right radius and ulna. The anesthesia plan, the patient was cooperative enough to come inside the OT. Induction was done under incremental sevoflurane, and a 22 gauge IV cannula was secured in the left upper extremity. Under all aseptic precautions, painting and draping was done of the right infraclavicular fossa, and a USG guided right infraclavicular block was given with injection bupivacaine 0.25% and injection lignocaine with adrenaline 1% at 0.4 ml per kg. So in this patient, we gave around 10 ml of local anesthesia. He was maintained with oxygen and nitrous 50:50 with 4 liters per minute of flow with SIVO at dial setting of 1.5%. This is the pre-operative X-ray with in situ tense nails of both the bones of the forearm with sustaining a refracture at the same side. So this is how we planned and managed the case. The patient was cooperative enough to come inside the OT. He was taken under anesthesia with incremental sevoflurane, and a mask was tied and the patient maintained spontaneous respiration throughout the procedure. This was done with a JR circuit. After this, a 24 gauge IV cannula was secured in the left upper extremity, and injection dexamethasone was given in zero point 0.1 mg per kg IV. A USG guided right infraclavicular block was planned for this case, and we deposited the local anesthesia around the axillary artery in a U-shaped form with 2 injections. The entire surgery was done under the right infraclavicular block. The patient had no intra-op complications. He maintained spontaneous respiration throughout the procedure with sevoflurane at 1.5% and oxygen and nitrous, and the vitals were maintained. There was no requirement of any rescue opioid doses. So we'll see the different sites and locations at which the brachial plexus can be blocked. Before that, we'll briefly discuss about the anatomy of the brachial plexus. The brachial plexus traverses the posterior triangle of the neck and the axilla. It provides complete innervation to the upper extremity, and it originates from the ventral primary rami of the fifth cervical spinal nerve to the first thoracic spinal nerve. It extends from the cervical spinal roots in the neck to its terminal nerves in the axilla. So this is the C5 to T1 nerve root. The C5 and the C6 forms the upper trunk. The C7 forms the middle trunk, and the C8 and the T1 forms the lower trunk. Uh, these trunks then have their own anterior and posterior divisions at the supraclavicular fossa. The trunks and divisions form a cluster around lateral to the subclavian artery at the supraclavicular fossa. Distal to the clavicle, these divisions reunite to form cords. The cords lie in the infraclavicular fossa relative to the position of the axillary artery, and these cords give off terminal branches in the axilla. So this is a more simplified diagram of the brachial plexus from starting from its roots to the terminal branches in the axilla. So depending on where we block what we block, there are different blocks of the brachial plexus. In the interscalene groove, we block the roots of the brachial plexus is the interscalene block. In the supraclavicular block, we block the trunks and divisions at the supraclavicular fossa. In the infraclavicular block, we have two types, the costoclavicular and the lateral infraclavicular. In both, we block the brachial plexus at the level of its cords, while in the axillary block, we block the terminal branches of the brachial plexus. So now we'll see the interscalene block first. These are the dermatomes, the myotomes, and the osteotomes that are covered under this block. The gross anatomy of the interscalene block, in the posterior triangle, the roots and trunks of the brachial plexus lie between the two scalenus anterior and the medius muscles at the level of the cricoid cartilage. All the cervical nerve roots from C3 to C6 exit from the intervertebral foramen and travel between the anterior and posterior tubercle of the transverse process. Deep to the cervical nerve root, the vertebral artery travels in the foramen transversarium from C6 to C1 vertebrae, and it ascends cranially, and that's how close the vertebral artery lies to the roots of the brachial plexus. So in this block, the position of the patient is supine or semi-sitting position with head turned to the contralateral side and the arm adducted by the side. The operator stands at the head end and the USG machine is placed according to the convenience of the operator. The probe we use in this is a high frequency linear array probe. In case of pediatric patients, we use a smaller footprint or a hockey stick probe. So there are two ways in which we scan the interscalene groove. We can either start a transverse scan at the midline of the neck at the level of the cricoid cartilage, which will be at the level of C6 vertebra, and keep scanning laterally till the lateral edge of the sternocleidomastoid. Or we scan transversely from the supraclavicular fossa. We locate the subclavian artery and then we sweep cephalad towards the interscalene groove. So this is called as the traceback technique. We place the probe at the supraclavicular fossa and locate the subclavian artery. We see the brachial plexus at posterolateral to the subclavian artery. As we go cephalad, we see the nerve roots coming out of the respective transverse processes, and they can be tracked upwards, lying between the two scalene muscles. So the sonoanatomy visualized at the C6 and the C7 nerve root. C6 is the first cervical vertebra when we come from supraclavicular fossa to have two tubercles of the transverse process, the anterior and the posterior tubercle, and the C6 nerve root comes out of the two tubercles. And the C7 nerve root has a distinctive feature which can be seen on USG, that it lacks the anterior tubercle, so it only shows the posterior tubercle with its acoustic shadow. The vertebral artery is best visualized at the level of C7, and it lies very close to the nerve root of C7 because of the absence of the anterior tubercle. So sonoanatomy of the interscalene groove, we see the trunks are located between the two scalene muscles, the scalenus anterior medially and the scalenus medius laterally. They are round to oval in shape and are hypoechoic in appearance with a hyperechoic rim. The carotid artery and IJV can also be visualized medially, and the vertebral artery can be seen adjacent to the C7 transverse process. The phrenic nerve can also be seen on the anterior surface of the scalenus anterior. The placement of these nerve roots give a typical appearance of a traffic signal. That is why this is also called a traffic signal sign or a stoplight sign. So this was a study done by Franco et al. which showed that the C6 and the C7 have significant intraroot splitting. So the three lights may actually be made up of just two nerves, which is C5 and a split C6 nerve root. So if we inject local anesthesia between the C6 and assuming that it is C6 and C7, it would actually end up being an intraneural injection at the C6 with risk of neuraxial spread of local anesthesia. So while performing the block, we introduce the needle in the transverse scan in plane approach from lateral to medial direction. We use a 22 gauge needle. The drug volume used is around zero point 0.3 to zero point 0.5 ml per kg. We try to deposit the LA between the epineurium of the brachial plexus and the epimysium of the middle scalene. A single injection is sufficient in this block. If we are using a pressure monitor, we try to keep the opening pressures below 15. We have to keep the opening pressures below 15 psi. This is the relation of the brachial plexus nerve roots to the cervical sympathetic chain and the vertebral artery. So if local anesthesia spreads towards the cervical sympathetic chain, we can have Horner's syndrome. While if there are very high chances of having an intravascular injection of the local anesthesia because of its close proximity to the vertebral artery. So this block is given in shoulder and proximal humerus surgeries. The USG is best visualized at the level of cricoid cartilage,
हेलो हाँ
which is at the level of the C6 vertebra. The lower trunk C8 to T1 may be spared in this. Because of the spread to the cervical sympathetic chain, its close proximity, we may have Horner's syndrome, and hoarseness of voice can happen because of its spread to the recurrent laryngeal nerve. Ipsilateral hemidiaphragm, because of the spread of local anesthesia to the phrenic nerve, is seen in most cases of interscalene block in adults. And for this, we can sonographically see the diaphragm excursions before giving the block and after giving the block. Because of its close proximity to the neuraxis, the local anesthesia can also spread to subarachnoid or epidural spaces. In pediatrics, this block is infrequently used because of limited indications of shoulder surgeries and because of the increased incidence of complications. So now we see the supraclavicular block. These are the dermatomes, myotomes, and osteotomes that are covered under this block. The supraclavicular fossa, in the supraclavicular fossa, the brachial plexus is relatively superficial. The trunks and divisions are seen as cluster of nerves on the posterolateral aspect of the subclavian artery. The subclavian artery lies on top of the first rib. The subclavian vein lies anterior to the scalene and scalenus anterior muscle on the top of the first rib. So in this block, the patient is in a supine position with head turned to the contralateral side and arm adducted by the side. A small roll or jelly is placed under the shoulder. This jelly is placed under the shoulder to increase the distance between the bed and the transducer, which will help for the in-plane approach of the needle and help in maneuvering the needle. This is especially useful in pediatric patients where the anatomy is very compact. The operator stands at the head end. The probe we use in this is a high frequency linear array probe or a hockey stick smaller footprint probe in very small children. The transducer is placed parallel to the clavicle in the supraclavicular fossa. The ultrasound beam is directed towards the first rib and the thoracic inlet. The first reference structure which we see in this is the subclavian artery as it crosses the first rib. So this is how we place the probe, and for optimal image acquisition, we can do a little bit of a tilting maneuver. The sonoanatomy seen is the trunks and divisions appear as cluster of hypoechoic needles, each with a hyperechoic rim. Collectively, these trunks and divisions appear as bunch of grapes on the posterolateral aspect of the subclavian artery. So while performing the block, we introduce the needle in plane from a lateral to medial approach, and we use a 22 gauge needle. The drug volume used is around 0.3 to zero point 0.5 ml per kg. We try to deposit the local anesthesia around the hypoechoic circles. According to the drug spread, we can either give single or multiple injections, keeping opening pressures below 15 psi. It is common to visualize one or more small arteries in this area, the suprascapular artery and the transverse cervical artery. So it is recommended to always use Doppler before performing the block to see the sonoanatomy and the path of the needle trajectory to see if there are any intravascular, any vascular structures in the needle's path. So this block is used in humerus and elbow surgeries. Because of the anatomical proximity of the cervical pleura, there are high chances of risk of pneumothorax. And if the subclavian artery is punctured, the hematoma formation can happen, which is difficult to apply pressure. The ulnar nerve may be spared because of lack of local anesthesia spread to the corner pocket. Even in this, we have risk of Horner's syndrome. The phrenic nerve block, which is 50 to 670% incidence, can happen, which is less than interscalene but still high. And recurrent laryngeal block is rare. In pediatrics, in younger children, the first strip may not be fully ossified, thus increasing the risk of a pneumothorax in pediatrics in this block higher. Okay, so now we come to the infraclavicular block. These are the dermatomes, myotomes, and osteotomes that are covered in this block. In this block, we have two components. One is the costoclavicular and the lateral infraclavicular. So the infraclavicular fossa is divided into two main areas. The medial infraclavicular fossa, it extends from the lateral border of the first rib cranially to the superior border of the pectoralis minor caudally, and it lies in relation to the first part of the axillary artery, while the lateral infraclavicular fossa lies deep to the pectoral muscles, the pectoralis major and the minor muscle, and they lie in relation to the second part of the axillary artery. So these are the two blocks which we see in the infraclavicular fossa. The blue position of the probe is seen in the costoclavicular block. In this, we see all the cords are lateral to the axillary artery, and we see the lung and pleura in the picture. While in the lateral infraclavicular block, which is near the coracoid process in a parasagittal, the green one, we see that the cords are placed in respective position to the axillary artery, while the lung and pleura is not seen in this scan. So first we see the costoclavicular block. At the medial infraclavicular fossa, the cords of the brachial plexus emerge from under the clavicle and enter the costoclavicular space, which lies deep to the pectoralis major and the subclavius muscle. Posteriorly, it has the upper slips of the serratus anterior. The cords of the plexus are clustered together lateral to the first part of the axillary artery. So this is how we see all the cords are clustered laterally to the axillary artery, and the axillary vein lies medial to the axillary artery. Superiorly or anteriorly, we have the pectoralis major and the subclavius muscle, and posteriorly, we have the upper slips of the serratus anterior. In this block, the patient's position is supine with the head turned to the contralateral side with arm abducted at 90 degrees. We use a high frequency linear array probe in very small children, a hockey stick probe. We transversely scan at the middle third of the clavicle with a little bit of a cephalad tilt. We see three cords lying lateral to the first part of the axillary artery. In this scan, we also try to scan and look for cephalic vein and the thoracoacromial artery. So this is how we place the probe parallel to the clavicle with a cephalad tilt in the middle third of the clavicle. So while scanning the medial infraclavicular fossa, we follow these following steps. The first step, we keep the probe on the clavicle. We see the clavicle with its acoustic shadow. We slip the probe below the clavicle, below the midpoint of the clavicle, and tilt it cephalad. We see the costoclavicular space with all the cords lying lateral to the axillary artery. We move further lateral to this, and we start seeing the cephalic vein arching over the axillary artery. It drains into the axillary vein uh, in this uh, in this scan. If we move further lateral to this, we stop, the cephalic vein disappears and we see the thoracoacromial artery. Further lateral, we start seeing the pectoralis minor and the lateral infraclavicular fossa. So while performing the block, the needle is introduced in plane transverse scan from lateral to medial approach. We use a 22 gauge needle. We, according to the drug spread and the sonoanatomy, we can either give single or multiple injections, a drug volume of 0.3 to 0.5 ml per kg. And the local anesthesia spread should be at the center of the three cords in the costoclavicular space. We should also scan for and see that the cephalic vein or the thoracoacromial artery are not in the needle's path or the needle trajectory. Opening pressures to be maintained below 15 psi. The cords of the brachial plexus are relatively superficial and they are clustered together lateral to the axillary artery. This block spares the phrenic nerve. A single injection of a relatively low volume is sufficient for this block as all the cords are clustered together. The costoclavicular space is a useful site for catheter placement for postoperative pain management because the cords are close to one another. Although in this block, there is a very high risk of inadvertent pleural puncture because of close proximity of the cervical pleura. So now we see the lateral infraclavicular block. At the paracoracoid location or the lateral infraclavicular fossa, the cords of the brachial plexus take up their respective position around the second part of the axillary artery and lie deep to the pectoralis major and minor muscles and anterior to the subscapularis muscle. In this, the lateral cord lies superior to the axillary artery, the posterior cord lies posterior, and the medial cord lies caudal to the axillary artery. Caudal to the medial cord, we see the axillary vein. Also to note that the pleura and lung are not part of the posterior relation of the brachial plexus at the lateral infraclavicular fossa. So in this block, the position of the patient is supine with ipsilateral arm abducted at 90 degrees and elbow flexed with the head turned to the contralateral side. The operator stands at the head end of the patient. The probe used is a high frequency linear array probe or a hockey stick probe for very small children. The transducer is positioned near the coracoid process in a parasagittal manner, inferior to the coracoid process. The first objective is to locate the axillary artery and the vein. It may be necessary to gently tilt, slide, or rotate the transducer to obtain an optimal view of the axillary artery. So this is how the patient is positioned with arm abducted at 90 degrees, and this is how the probe is held in a parasagittal manner below the coracoid process. The entry of the needle is from a cranial to caudal direction. So sonoanatomy, superficially we see pectoralis major and pectoralis minor. Deep to it, we see the axillary, second part, axillary artery, and in relation to it, we see the lateral cord, posterior cord, and the medial cord, as well as the axillary vein. The lateral cord lies at the 10 o'clock position, the medial cord at 3 o'clock, and the posterior cord at the 6 o'clock position. So while performing the block, the needle is introduced in plane in a parasagittal scan, cranial to caudal approach. We use a 22 gauge needle and the drug volume is 0.3 to 0.5 ml per kg. Depending on the drug spread, we can give single or multiple injections for local anesthesia to spread in a U shape around the axillary artery and opening pressures to be kept below 15. So in pediatric patients, we also give this block with PNS. So uh, uh, the landmark is 2 centimeters medial or inferior or 2 centimeters inferior to the coracoid process. We feel two pops of the pectoralis major and the minor and get the response. The response is stopped below 0.2 to zero point 0.3 milliamperes, and that is when we inject the local anesthesia. So the ultrasound visualization at the at the lateral infraclavicular fossa is best achieved with the arm in the abducted position. This is because in abduction, the cords come superficial to the skin, and the lateral side of the clavicle head goes upwards, which gives more space for the transducer and maneuvering of the transducer. The posterior acoustic enhancement effect can sometimes be misinterpreted as the posterior cord, posterior to the axillary artery. The pleura should be routinely identified as part of the scan, and the needle should be inserted lateral to this side. That is, we should get an ultrasound window where there is no pleura is visualized. This decreases risk of any inadvertent pleural puncture. The lateral infraclavicular fossa is a popular site for brachial plexus catheter placement, as the muscles of the chest wall help stabilize the catheter and may prevent catheter dislodgement. This spares the phrenic nerve. In pediatric patients, the coracoid process may not be ossified and well defined and will be difficult for the landmark technique, but it is the most commonly used block in pediatric patients because it spares the phrenic nerve, and also it is away from the pleura. So now we'll see the axillary block. These are the dermatomes, myotomes, and osteotomes that are covered in the axillary block. The brachial plexus enters the arm, and its four main terminal nerves, the median, ulnar, radial, and musculocutaneous, travel in close proximity to the third part of the axillary artery. The nerves lie superficial to the conjoint tendon, which is formed by the teres major and the latissimus dorsi muscle, and under the subcutaneous tissue lateral to the anterior axillary fold. We can see the musculocutaneous nerve lies between the biceps brachii and on the lateral side of the axillary arm. The musculocutaneous nerve lies between the brachialis and the biceps brachii and this muscle. There are a number of different variations of the nerves that lie in relation to the axillary artery in the axilla, but the most common configuration that we see, the median nerve is located between 9 and 12 o'clock position above the axillary artery and below the biceps muscle. The ulnar nerve is positioned superficially between the axillary vein and artery at 1 and 4 o'clock position. The radial nerve lies above the conjoint tendon at 4 and 6 o'clock position, while the musculocutaneous generally branches off from the plexus just below the clavicle, and it can be localized at 9 o'clock position on the same side of the median nerve. In this block, the patient's position should be supine with the ipsilateral arm abducted 90 degrees at the shoulder. We use a high frequency linear array probe or a hockey stick probe. In the axillary fossa, we keep the probe perpendicular to the axillary folds. We see the axillary artery, we locate the axillary artery and the vein. The axillary vein are compressible, and the compressibility can be used to differentiate between the artery and the vein. We can also use Doppler for the same. The conjoint tendon should subsequently be identified as all the nerves lie above the conjoint tendon. This is the position of the patient while the probe is held in this position. So we see lateral to the axillary artery, the biceps and the coracobrachialis and the musculocutaneous lying between the two muscles. In this scan, we see the median nerve at around 12 o'clock position, the ulnar nerve at 2 o'clock position, and the radial nerve around 6 o'clock position lying above the conjoint tendon. While performing the block, the needle is introduced in an in-plane in a lateral to medial direction, and we use a 22 gauge needle. The local anesthesia spread should be in the axillary neurovascular sheet between the axillary artery and the conjoint tendon. We can either use a 2-point injection technique or a 4-point injection technique. We can inject periarterially or by surrounding each individual nerve with the local anesthetic. The musculocutaneous nerve has to be blocked separately with local anesthesia deposition around the musculocutaneous. So this is a 4-point injection technique of the axillary block. We start by dynamically scanning the axilla to identify the musculocutaneous nerve between the two muscles, the coracobrachialis and biceps. We also scan for the axillary veins. So this is the musculocutaneous nerve. We keep the conjoint tendon below the artery and identify the three nerves around the artery. So we start by dissecting between the nerves by hydrodissection. We scan well for any vascular structures present in the needle's path. So here we are going above the axillary artery to reach the median nerve and the musculocutaneous nerve by hydrodissection. And we'll deposit local anesthesia near each nerve. So this is a 4-point injection technique. So, in the axillary region, there are anatomical variations in the location of the nerves and the number of the axillary veins. The location of the nerves can be verified by tracing the course of each nerve. The axillary region is highly vascular, and the examination of the brachial plexus in this area should be preceded by a careful examination to locate the arteries and veins around the potential target nerves, because there is a very high risk of intravascular injection in this area, in these blocks. This spares the phrenic nerve. In pediatric cases, it is used bilaterally for bilateral reconstruction surgeries, bilateral hand reconstruction surgeries. So special points to be mentioned for upper limb blocks in pediatric cases. All the blocks in pediatric cases are done under general anesthesia or deep sedation, and they carry a very high safety profile. Frequent aspirations and pressure monitoring, if available, should be done while injecting the local anesthesia. Due to the compact anatomy and the rich vasculature of children, there are higher risk of complications like pneumothorax and intravascular injections. That is why I highly recommend USG guidance for giving blocks. USG guidance also helps in lowering the concentration and volume of the local anesthesia. Caution with use of adjuvants as they increase the duration and the intensity of the block. So the drugs we use in pediatric patients for single shot peripheral nerve blocks, we use 0.1% or 0.25% bupivacaine, levobupivacaine, and ropivacaine at 0.3 to 0.5 ml per kg. And for continuous catheter peripheral nerve blocks, we use 0.125% bupivacaine or 0.1 to 0.2% ropivacaine at a rate of 0.1 to 0.3 mg per kg per hour. Low concentration and volume of LA should be used in pediatric patients as compared to adults, as it decreases risk of neurotoxicity or any peripheral nerve injuries. They are less likely to mask any compartment syndrome post the surgery. And because of the different anatomical, physiological, and pharmacological variations between pediatrics and adults, there is children are at higher risk of LAS. So this also decreases the risk of local anesthesia systemic toxicity. So this was a retrospective cohort study of 565 cases for brachial plexus block with ultrasound guidance for upper limb trauma surgeries in children. They had a success rate of 94.9% for upper limb blocks in children under various levels of sedations, and upper limb blocks can be performed with high probability of success and excellent margin of safety. Pediatric regional anesthesia provides opioid sparing pain relief and ensures optimal analgesia, and reduces the duration of the hospital stay. And it should be considered for all the children undergoing surgery. Thank you.
Mantra, that was a nice presentation. You covered most of the aspects of the pediatric regional anesthesia related to upper extremity. Just a few corrections over here. Before we go on to asking questions, I think in your diagram, can you just go back to your diagram of the brachial plexus? I think it was the third or the fourth slide. The initial slides where you have shown the brachial plexus. There were some mistakes in the diagram, so I would just like to clarify. Is annotation allowed over here? Can you see over here? There is no C8 in the picture. Just go back to that diagram.
Yeah, there is no seating.
There is no C8 in the picture. So just make that correction. Don't use this diagram because C8 and T1 will be forming the lower trunk and there is no C8 shown in this picture. I think the next diagram also doesn't have a C8. The next picture that you have, the one after that. Uh, yeah, so this also doesn't have a C8 in this. So just make this correction because C8 is always there. Most of the cases you will see a C8. Another thing that you mentioned, I think, which is not right, is pediatric interscalene block. I think you said that interscalene blocks is not used. So that is not the case. Actually, for shoulder surgeries, if you want to cover a suprascapular nerves, then you will have to use interscalene blocks. But it is just that when you have a surgery below the elbow, then I would prefer an infraclavicular approach or an axillary approach to any supraclavicular approach because you would get the same action with a lesser incidence of complications. So the preference for pediatric blocks is always infraclavicular for surgeries which are distal to the elbow. But any surgery which is in the proximal humerus and shoulder surgeries, then we will of course use interscalene blocks. So that is a small correction over there. I think another thing that you said which was not right was, I think, which I would like to clarify is your division of the medial and the lateral infraclavicular fossa. So, what divides the medial and the lateral infraclavicular fossa, which is the muscle which will divide the infraclavicular fossa into a medial and a lateral half? So, I think that is what.
Pectoralis minor.
Right. Yeah, so pectoralis minor is the muscle which will divide it into the medial and the lateral halves. And another thing that you kept on mentioning was in the infraclavicular block with the subcoracoid approach that you mentioned it as the second part of the axillary artery. So usually it is the third part of the axillary artery. So the first part of the axillary artery, which many people mistake, is when they do costoclavicular block, they mention the artery over there as the subclavian artery. It is not the subclavian artery. It is actually the first part of the subclavian artery. Then what you have below the pectoralis minor is the second part of the subclavian artery, and beyond the pectoralis minor is the third part of the axillary artery. So when you are doing infraclavicular block, it can be the second or the third part of the axillary artery.
Okay.
Yeah. And another thing which was not clear was, I think your PNS slide. Just go back to the PNS video. Yeah. So what we wanted to demonstrate over here was that we were getting a response at point 0.5. So we are getting a lateral cord or and medial cord response over here. So any response beyond the wrist we will accept. So we are getting a good response at point 0.5. And when we reduce to point 0.2, the response has disappeared. So why do we want to check this? And again, we increase to 0.5 and again the response comes back. So that is something that I think you covered it very hastily. So why do you want to check whether the response disappears at point 0.2 and point 0.3?
To see if there is any risk of intraneural injection.
Yeah, so this was something that was not clear. So rest of the presentation was okay. Just these were some corrections that I wanted to clarify before we go on to the next topic. Now, Sangamitra, do we want to do the introduction first or should we go on to the questions?
I think
I
we
think
will get the introduction, sir, so that we know the fellows.
yeah, okay. So can
So
we
you
start institute wise? Can we start with the with since CAS is doing the presentation, we'll start with all the CAS fellows. So Antra is our first fellow. She is with me in CAS. Shefali, can you introduce yourself?
Good evening. I'm Dr. Shefali from CS Mumbai.
Can you switch on the camera?
Yes, sir.
All the fellows, please switch on the camera.
Yes.
Yeah. Is Arya there? Has Arya joined? Arya is not joined. So can we go on to Holy Spirit now? Kapil, can you introduce yourself? Kapil, you are on mute. Just unmute yourself.
Yeah, thank you, sir, for that. Good evening, everyone. I'm Dr. Kapil Khandelwal from Andheri East. I've joined as a fellow in Holy Spirit Hospital under the mentorship of Dr. Vishali Ponde, ma'am. And the other mentors at the hospital are Dr. Deepika Shukla, Dr. Namita Parikh, Dr. Tarana Sheikh, and Dr. Snehal Panchal. And I've also worked with Dr. Ankit Desai for a couple of months.
Yeah, thank you, Kapil. Mulund Fortis, do we have the Mulund Fortis fellow?
Yes, sir. Good evening, sir. I'm Dr. Rutuja at Mulun Fortis Hospital, Yehuda Fellow. My mentors are Dr. Vijay Shetty, sir, and Dr. Seema Vaidyan.
Yeah. Welcome, Rutuja.
Thank you, sir.
Next, yeah. Then Kokila Ben, do we have the Kokila Ben fellow? I think Kokila Ben is not there. So Ruby Hall.
Hello.
Dr. Tejas, yeah.
Good evening, sir. I'm Dr. Tejas. I'm doing the
Hello.
fellowship under Dr. Dikshit, sir.
Yeah.
Yeah, next person. Hi. Yeah, welcome, Tejas. Welcome to the AORA cluster group. Are you the single fellow, or do you have any other colleagues with you?
Yes, sir. I am alone here under Aura Fellowship.
Okay, okay. So can we go to the next hospital? I think Sterling Nicholson's hospital. Just
Good
introduce
evening,
yourself.
sir. Good evening, sir. This is Dr. Harsha Deshpande. I am Aora Fellow at Sterling Hospital under Dr. Kumar Badera.
Okay. Welcome to the AORA cluster group. Then do we have Ritesh sir's fellow over here?
No, sir.
He's not.
Yet
So who's remaining
he
now?
join in June or July.
Okay, okay.
There is Dr. Kishore from Kokila Band.
Okay, Kishore is also from Kokila, right?
Yes, sir.
Yeah. So everyone is introduced now?
Hello, sir. Good evening. This is Dr. Naveen, sir, AORA fellow at Sanchetty Hospital under Dr. Divan, sir.
Okay, okay. Hi, welcome, Naveen. Sorry, I
Hello,
forgot.
sir. No problem,
Right.
sir.
Naveen has done the first presentation on basics, sir. It went very well.
Okay. Yeah, okay, okay.
Thank you.
Yeah.
So, all right, I think all the fellows have introduced. So, can we go ahead with the question answer session, sir?
Yeah, we'll go ahead with that. So we'll just clarify certain fundamental differences between pediatrics and adult blocks. So I would like someone to answer. I think Antra only can answer. What is the basic difference between adult and pediatric blocks? So what exactly is different in adult and pediatrics? I think you covered it in bit, but just once more, can you just explain what is the basic difference between pediatric and adult blocks?
So the main difference is that in pediatric patients, we give the block under general anesthesia or under sedation. The patients are not awake, and the uh, we give because of this the patient cannot report any paresthesia or any pain on injection. So we have to be cautious with our use of local anesthesia drugs. Also, the use of local anesthesia because of the pharmacological differences such as increased cardiac output and immature hepatic metabolism. The local anesthesia used the concentration used is lower, and there is also a risk of compartment syndrome in pediatric patients, and because of that we are cautious with our use of adjuvants.
Yeah. So the basic difference between pediatric and adult blocks is you have to give some kind of sedation in pediatric blocks. In adults, most of the blocks we try and do them awake. Of course, we can do them under some kind of sedation if the patient is not cooperative. But all pediatric patients, you will have to do them under some kind of sedation. It can be a deep sedation, it can be general anesthesia, it can be general anesthesia with or without relaxant. So it depends on your setting, the type of block. But the basic difference that we have between pediatrics and adults is because we are giving this sedation, our early signs of intravascular and intraneural injections are lost. So, say you have an awake adult patient, when the drug goes intravascular, he may complain of, say, some kind of tinnitus before we start getting some ECG changes or convulsions. So, those early signs are lost because patient is under some kind of sedation. Also, when you give intraneural injections, in an awake patient, your patient will complain of pain, which is not there when you are doing pediatric patients since you are doing the block under sedation. So you have to be aware of this and you have to take adequate precautions whenever you are doing any kinds of blocks. So my next question to you is now what will you do or how will you prevent an intravascular injection or an intraneural injection? What all precautions you will take? I think
Uh,
Shefali can answer this, or Antra, you can answer. It's okay. Kiran
uh,
also you can chip in. Kiran is my co-moderator, so Kiran is also one of our partners in the CAS group. So Kiran also can chip in with her questions.
Yeah, sure.
Yeah. Antra, go on.
um, Sir, in pediatric patients, we according to the weight of the patient, we'll first calculate the dose of the local anesthesia to be given before the block, and of the concentration and the volume has to be on the according to the age and the weight of the patient. To avoid any intravascular injections, it is better to use a USG so that we can scan and see any vascular structures. Also, when we see the drug spread on the sonoanatomy, we understand that we are not going intravascular, and we the drug which we use, I mean, we have to remain extraneural, extravascular to avoid any uh, intraneural injections. We can also use PNS pressure monitors, so it can be a triple guidance. We keep the pressures below 15 PS opening pressures, and with PNS we see if the response is disappearing at 0.3 milliamperes. And
Yeah, so it mainly covers all the points what you have rightly said, that for preventing intravascular, we always aspirate, we look for signs in the ultrasound. But main thing is you always give the drugs very slowly. So whenever you are doing any pediatric cases, always make sure that you don't exceed the toxic doses and you give your drugs in slow incremental doses. Don't push your drugs very quickly because the patient is under sedation and we will not come to know about intravascular injections unless a very high dose goes inside. So
Another,
those are the
One,
yeah,
Dr.
yeah,
one,
one
Kapil
more
wants
thing
to add something.
yeah.
here.
No,
Sometimes
ma'am,
it,
I just wanted to add the aspirational point which Ankit sir mentioned later.
Okay.
Yeah, another point I want to add is always go for in-plane approach whenever possible, so that you can visualize the needle shaft as well as needle tip. So when you see the needle tip, there are less chances of intravascular as well as intraneural injection.
yes, sir.
Yes, sir.
in pediatrics, sometimes it may happen that because of the anatomical variations, the trajectory of the needle, which we insert, let's say from skin, subcute muscle till your nerve, it may have some inadvertent anatomically not very well defined vessels. So it is always wiser to use Doppler actively and see if we are not in or around any vessel which is not expected to be there. So it is always better before you start injection, just put Doppler and see where your needle tip is, and have you crossed any vessel or any anatomically different structure before you start your injection actually.
So that is very important. You need to check Doppler. So it is always a good practice to do a scout scan before you start washing up. So during your scout scan, just make sure that the anatomy is normal. You look for any aberrant vessels. I think you mentioned that there can be transverse cervical arteries in the supraclavicular approaches. So you look for all those variations. And one more thing you can do is while doing the block, you can use Doppler. So sometimes Doppler, what it does is picks up motion. So when you are injecting the drug, even that motion, the movement of the drug can be picked up with Doppler. So if you use active Doppler and if it is not interfering with your image, that is one strategy that you can use for pediatric patients. You can use Doppler at very low gains to look for any movements of the drug that you inject. Sometimes you will be able to see drug movements with it.
Yeah, Ankit,
Yes.
Dr. Ritesh.
Yes, sir. Hi.
Yeah, hi. One more tip I want to just give to all the fellows. When you are putting a color Doppler to see the vessels above clavicle, usually the vessels are very superficial. And to see the structures, you put a certain amount of probe pressure, right? So when you are searching for putting the color Doppler mode, lighten your probe pressure. Otherwise, what will happen with the same pressure where you are scanning and you are putting a color Doppler, you might have pressed the vessel. So
Yeah.
able to see the vessel. So just lighten your pressure, then put a color Doppler and then see. Okay.
Yeah. So not only for supraclavicular approaches, even for axillary approach, even for a simple block like axillary approach, what we have found is many times you will see instead of one axillary vein, you may see as high as four veins. I have seen patients having four axillary veins in the same area. So unless you reduce the pressure, you don't come to know about these veins. So try and keep the pressures as low as possible. And what we do commonly is when we hold the probe, we always try and rest the probe, rest your fingers against the probe. So when you rest your fingers against the probe, then the pressure that is applied by the probe on the skin is always lesser. So that is one technique that we commonly apply for all these blocks, especially the superficial blocks.
So basically, the importance of scout scan comes because once we are learning blocks in the beginning, we are very excited to put the needle fast. But our fellowship teaches us that first the scanning time should be maximum to do all these things. The needling part is very exciting, pushing the drug is very exciting, but we should spend more time on scanning. So that is an important part in our training, and we should take care of that.
Yeah. So coming to the next question, Antara, what are plan A blocks? So in this case, you were doing a distal end, I think middle radius ulna fracture. You selected, I think, infraclavicular block, the lateral infraclavicular approach. But in pediatrics, there is an article in RAPM in 2023 where they have mentioned all the plan A block. So what is the plan A block for pediatrics in the upper extremity?
I have not gone through the article, sir, but
So anyone can answer. Whoever knows this can answer. Any of the fellows can answer. What are the plan A blocks for pediatrics? Any of the fellows? So in plan A blocks for upper extremity, it is the axillary block, which is the safest block. So plan A block for upper extremity blocks in pediatrics is axillary. We prefer the axillary approach because the complication rate with axillary blocks is the safest. It is the most further away from the pleura. Also, the phrenic nerve involvement is close to zero. It is zero for all pediatric blocks. So that is the reason. In fact, axillary block is the plan A block. Plan B block is infraclavicular and or your supraclavicular blocks, which you mentioned. Costoclavicular block in pediatrics, it's a bit difficult to do. You can give in older children where you clearly see that the pleura is very much away from the cluster of the cords that you see. So costoclavicular block is not very common in pediatrics, but you can give, if you have good dexterity, you can use costoclavicular blocks in pediatrics. But the plan A block is always the axillary approach. And Antara, I think your video was very good, in which you showed the 4-point injection. Are there any other ways of giving the axillary block? Can you just go to the video of the axillary block again? So there are actually 3 ways you can give your axillary block. What you mentioned was the 4-point injection. So is there something called 2-point injection, and what is 3-point injection? Just play the video, Antara. I'll tell you where to stop.
Okay.
Just click on the video. Just wait on the slide and go to, yeah, click on it. Can you just stop the video there? Just stop the video. Just stop playing. Yeah. So what you have explained is the 4-point technique. Can you just explain what is a 3-point technique and what is a 2-point technique?
So 2-point is when we give it around the artery.
Yeah. So
And
perivascular injection is the 2-point technique. So one, you inject over the artery, and other. So here, if you inject in two ways. One is over the artery and one is under the artery. So that is a 2-point technique. What is the 3-point technique?
not sure, sir.
So besides the perivascular injection, you can see that this musculocutaneous nerve is outside this sheath. So what is this sheath? So can you see this sheath over here? So this is the sheath that is being formed. So this sheath is called as the brachial plexus sheath. It is formed by the extension of the pre-cervical vertebrae, or it's which forms the brachial plexus sheath. Some people like to call it paraneural sheath, but the appropriate term for it is the circumneural sheath. So circumneurum because it is surrounding the nerves. So it is an appropriate circum because circum means surrounding. Para means something that is besides or to the side of the structure. So circumneural sheath is the most appropriate term for the brachial plexus sheath. So what we are seeing is this is the extension of the pre-cervical vertebra. It is seen throughout. Like you will see the circumneural sheath even in the supraclavicular area, costoclavicular area, your lateral infraclavicular approach, and your axillary approach. So the idea is to deposit below the this prevertebral fascia or the axillary sheath or the brachial plexus sheath. So this musculocutaneous nerve is always, or in most of the cases, in 90-95% of the cases, it is outside this sheath. So that is the reason you have to block this musculocutaneous nerve separately from all these three nerves. But when you are beyond this sheath and you have injected above and below the artery, most of the times you will get a good spread and you will get complete blockade. In 5%, like around, I think it's around 12%, this musculocutaneous nerve may be lying close to the median nerve. So in many cases, it may be within this sheath and it may be lying very close to this median nerve. In that case, even if you do a 2-point injection, it will suffice. So this is very important. And having said that, one of the very important concepts that you have to understand in pediatrics is the diffusion rate in pediatrics is very high. So even if you are further away from the nerves, the chances of you getting a successful block is very high. Adult blocks, you will see a lot of compartments over here. So this 4-point injection is more relevant when you are doing adult blocks. But in pediatric blocks, even if you location and if you give a high volume, then there is a very high chance that the drug will spread to all these nerves and you will get a very good block. This holds true for all the blocks in pediatrics. So this is something that you have to remember.
Yes, sir.
And I think one more thing that I forgot to mention was what you said was in costo the phrenic nerve involvement is zero. I don't think it is 0%. I think a good number would be around percent. I think Ritesh sir and Hetal sir can add to
minimum
this.
5%.
Yeah, so it's not zero. Yeah, it's there can be phrenic even with your costoclavicular approach.
Okay, sir.
Even with paracarotid approach, there are some reports of phrenic nerve palsy.
Yeah.
With higher volume.
Yeah.
Ritesh,
Dr. Antara,
Yes,
regarding the interscalene injection, you told what are the different types of injection which you apply in interscalene? You have shown in your slide that you deposit the drug between the epimysium and the epineurium. That's a daring disclosure. Depositing the drug between the epimysium and epineurium. So what are the two injection strategies of interscalene approach?
So we go between the two so that we avoid any intraneural injection because of the splitting.
There's a name of the two injections. Any fellow can answer.
Uh, Sir, good
Yeah,
evening,
Naveen.
sir. This is
Good
Naveen
evening.
from
Yeah,
Sancheti Hospital.
yeah,
Sir,
Naveen.
this one is periplexus and another one is intraplexus, sir.
Yes. Okay. So where you deposit in periplexus and what is periplexus and what is intraplexus?
Sir, periplexus is between the epimysium and the circumnurium, sir.
Okay.
Where the intraplexus is, we have to pierce the circumnurium and place the drug between the epinurium of C5 and C6.
Okay.
That is
So
intraplexus, sir.
okay, that is intraplexus. So is it practically possible seeing seeing the with the ultrasound machines which we usually have, is it possible to see the circumnurium, the epinurium? Okay, epinurium you can delineate, but getting that epinurium, circumnurium is slightly difficult with the machines which we have. So
Yes, sir.
what is the approach which you follow in your institution?
Sir, we usually give a periplexus approach, sir. And some
Okay.
patients we have given intraplexus also.
Mm-hmm.
And in the periplexus approach, we can see the drug which is spreading as a half moon, sir, in the posterior to the plexus. And in intraplexus, see the drug which is spreading inside, sir.
Okay. So
So
and what is
we may not be able to see circumnurium in the ultrasound machine, sir. But while going inside the plexus between C5 and C6, we might able to see a pop, sir.
right?
We can feel a pop.
Okay. Uh, so what is the advantage of giving a periplexus injection?
Sir, so the article says that analgesia is similar in periplexus and intraplexus, sir. But the incidence of paraesthesia and the faster onset of block is higher in intraplexus than periplexus.
And any complications which have been reported that it is less with a periplexus compared to intraplexus?
Sir, I think epidural spread of the drug, sir, I'm not
Any
sure.
common complication? I'm giving you a hint.
So phrenic nerve.
Sir,
Yes,
phrenic
the
nerve.
phrenic nerve palsy, the incidence of phrenic nerve palsy is less. It has been reported that it is less. Okay, but
Yeah,
that
yes, sir.
doesn't mean that a person has a ipsilateral phrenic nerve palsy and you are trying a periplexus injection. Don't do that. Okay.
Okay, sir.
Okay,
Okay,
the
sir.
incidence is less, but incidence is not zero. Okay,
Okay,
so
okay, sir.
yeah, so the periplexus injection, the incidence of phrenic nerve palsy is less compared to the intraplexus injection. Okay, and the
Okay, sir.
onset
Okay,
is
sir.
the only disadvantage with a periplexus injection is the onset of block takes longer, so you
Yes,
have
sir.
to wait. Okay,
Yes,
okay,
sir.
yeah, thank you.
Thank you, sir.
I think having said that, I think there is a editorial recently in RAPM where Javier Salablanche, etc., they have mentioned that even if you go intraplexus, then there is a difference between going intrafascicular and extrafascicular. So because they have, I think, changed the dye that they use. So now previously what they were using was India ink. Now what they use is 15% erythropoietin, that is the blood sample, which they use as a dye. And what they have found in the electron microscopy studies is even with intraplexus injection, there is a difference between being intrafascicular and being extrafascicular. But we don't have to go intraneural for that. But just for comment sake, I'm just mentioning there's a lot of new research going on regarding this between intrafascicular and extrafascicular injections.
Another thing I want to clarify regarding PNS guided pericurve approach, what Antika said is you have to go 2 centimeter medial and 2 centimeter podal, right? So it is true for adult patient, but is it same for pediatric patient? I want to ask Ankit as well as to Antra. So for Santra,
Sir, we go 2 centimeters inferior.
so it is same in adult as well as in pediatric patient, or is there any difference?
In adults, we go medial and inferior. In our patients, we go only inferior to
Okay,
avoid.
okay, okay.
So we try and
Ankit, any?
avoid going medially because we don't know where the pleura is lying unless you have a
Yeah,
ultrasound machine.
true.
So we go just caudal, and 2 centimeters is arbitrary. So 2 centimeters is for adults. So if you have say 15, 20 kg child, then I go just 1 centimeter below. So it depends on the
Okay.
weight. There are no studies as such regarding the distance from the coracoid process, but you have to just assume that if it is 20 kg, then you don't have to go 2 centimeters below. You can go 1.5 centimeters below, and you get a good response.
Yeah,
Yeah.
that's great.
So
So, Antara, why
Antara,
you? Yeah,
sir, go on,
someone
go on.
was. Yeah. So, Antara, why you choose pericoracoid approach over other approach? Like Ankit said that first you should go for a axillary block, then you should choose approach like infraclavicular or costoclavicular. Why you choose this pericoracoid approach over axillary approach in this patient?
Sir, we get s- uh, the s- uh, the dermatome and the myotome which are covered are better in infraclavicular, and also because of
But this is a forearm surgery. Can't you cover all this dermatome and
yeah
myotome with axillary block also?
yes sir, but and in axilla we wanted to it was a very vascular scout scan, so we went for infraclavicular in this child.
So after scout scan, you decided that you will go for pericoracoid over axillary.
Yes sir.
Okay, okay. And another question comes to my mind is you use ultrasound guided technique, and you have mentioned repeatedly about using pressure monitoring device and PNS to prevent nerve injury. Why you choose only ultrasound in this patient? I'm not saying it is wrong, but you prove yourself.
Uh, Sir, in that setup, we didn't have the availability of the pressure
Okay.
monitor and the
Okay,
PM.
you didn't have PNS and you didn't have ultrasound. So how you can prevent nerve injury with ultrasound only? This is repeat, but for the sake of discussion.
For nerve injury, sir, with an ultrasound, so we uh, see the drug spread, and we can also use hydrodissection to avoid any direct needle to nerve contact. And, we can decrease we choose the local anesthesia drugs and decrease the volume and concentration of the drug. And we also um, try to not go intraneural and intravascular and stay out of the on the sonoanatomy while give, and
Okay,
we see the entire needle path as well as the tip of the needle while
okay,
performing the block, and in play and try to do it in an in plane approach.
okay. Another question I want to ask is you said something about an artifact in intraclavicular approach, right? What was that?
Posterior acoustic enhancement.
So how can you avoid it? Suppose you are getting some artifact, you are not sure whether it is nerve or artifact. How will you identify whether it is nerve or not?
Sir, in this case, we can either tilt the probe to
Okay,
decrease
very
it,
good, very good.
or if we are unsure if it is a artifact or a nerve, we can trace the nerve. So
Anything else?
we can see the path, and we can use PNS stimulation.
Very good. Anything else? You can inject some saline or drug, whatever, and if it is a nerve, you can see the nerve as a brighter structure after injection of the drug, and you will be sure that whether it is nerve or not, right?
Okay. Yes, sir. Yes, sir.
Okay, very good.
Atra,
Ankit,
my
go
next
ahead.
question to you is what additives can you use, and why in this particular case we have not used any additives? In
Um,
general, in pediatrics, what additives can we use?
Sir, we can use clonidine,
Doses also you
1 to
mentioned.
2, 1 to 2 mics per kg. and clonidine, uh, or dexmedetomidine also in the 1 to 2 mics per kg.
Which are the approved ones and which are not approved and which we use off-label?
Clonidine is approved
Yeah.
and dexmed is not approved, I think.
Okay. What other additives can you use? Dex
Dexamethasone,
yeah, dexamethasone is approved or not approved?
not approved.
I think dexamethasone is approved, so we can use dexamethasone. Others are opioids. So dexamethasone in a dose of 0.1 milligram per kg you can use, and dexamethasone and clonidine are the ones which are approved. So why in this particular case we have not used? I think you mentioned this, but I think we have not discussed this. Why we don't like to use additives in acute fractures?
In a case, this is a case of trauma, so we were selecting if in case if we have a compartment acute compartment syndrome post the surgery, we don't want the block to be very dense and for a prolonged duration of time, so we avoid using adjuvants, and that's why we avoided in this case.
Yeah, so that is the main reason why we avoid these additives in these kinds of acute cases. In chronic cases, we do add additives, so something like a radial club hand or some any congenital anomalies. All those kinds of cases, we do like to add additives, or we do put some catheters if required. But for acute trauma, generally, at least in my cases, I avoid the use of additives because we are always worried about compartment syndromes. Now, compartment syndrome is most common for which fractures? Which fracture is the most notorious one for
Tibia.
compartment syndrome? Yeah, so tibia fracture, lower extremity is the most common. Other two fractures where it is very common is supracondylar and radius ulnar fracture. So these three fractures are notorious for compartment syndromes. So basically, the current literature or current knowledge that we have, it is very difficult to sometimes convince the surgeon because surgeons will just say that they want to detect compartment syndrome. So if you give block, then the pain will be masked and early signs of compartment syndrome will be missed by them. So many surgeons will not allow us to give block. So what do you tell the surgeon? So what is the current literature regarding this?
Also, there is no evidence that the regional anesthesia increases the risk or delays diagnosis of compartment syndrome. So, in case of an acute compartment syndrome, the patient will have out of proportionate pain. So, it will be like a breakthrough pain. Even if the child is given a block, the child will be still in pain in spite of the block, and that will be a marker of diagnosis of the acute compartment syndrome.
Yeah, so that is very important. So even with the block, if the child starts getting pain, because vascular pain is very severe, even with the block, they will start getting pain. It is something like a tourniquet pain. So with tourniquet pain, even if you have given a block, the block has acted well. After 1 hour, the patient may start complaining of tourniquet pain. So that pain is vascular pain. Similarly, in compartment syndrome, also what you get is vascular pain. So despite your block, if you are getting some pain. So breakthrough pain with block is one of the early signs of getting a compartment syndrome. So what you have to tell the surgeon is what we will do from our side is we will not use any additives. We will use the shortest possible acting local anesthetic so that the action of the block will wear off as soon as possible. So that is something you can do. So what you can do is you can reduce the concentration of the drugs that you can use. Sometimes I use only lignocaine. I avoid giving bupivacaine if the surgeon is very worried because the action will wear off in intra-op only. So post-operatively, the surgeon will be able to monitor the neurological function and he will be able to look for early signs of compartment syndrome. So, and besides that, most important is pressure monitoring. The surgeon has to monitor the pressures for early detection of compartment syndrome. From his end also, he has to take care and he has to monitor this compartment syndrome. So after this lecture, what I'll do is I'll put there's something called as the 7 pillars for early detection of acute compartment syndrome. I'll be putting that photo on the group when we finish. You can just go through that photo regarding that compartment syndrome.
Any doubts from fellows side?
Yeah. Any fellows, you
Any
have any
queries?
questions? Yeah, any questions, any queries from your side? Even mentors can ask or anything they want to add.
Sir, can you please explain the 3 point technique for axillary block again?
Yeah, so 3 point technique is the same. You give one injection that is above the artery, second injection is below the artery, and the third injection is near the musculocutaneous.
Okay.
Yeah.
Okay, sir.
Any other questions from the fellows?
Andhra, please stop sharing your presentation.
Just for discussion.
Yeah. So, sir, you should first thing I would warn everyone that if you are not used to doing pediatric cases, putting an IGL or securing the airway is far better than using our mask techniques. Only if you are a trained pediatric anesthesiologist, you should be using your the mask technique that we describe. When you use a mask, uh, nowadays what we see is most of the times we have the success rate of our blocks is very high. So once your block has sort of acted, so the case happens just in regional anesthesia. So it's like something like an adult case happening in regional anesthesia with some kind of sedation. So your sevoflurane levels and depth of anesthesia you can get down to very low levels. So sometimes I would be putting the sevoflurane to as low as zero point 0.4 to 0.6%. So the surgery will happen only under regional anesthesia. So I would not call this GA plus regional block. I would rather call this as regional block plus sedation. So that is the technique that we use. But of course, you have to know at which stages what you have to employ. So initially, when we start the induction, it is always a deep plane of anesthesia. We secure the IV line. That time also the patient is very deep. When the surgeon is taking an incision, that time also the patient is deep, and only once we are sure that the block has acted and there is no stimulus, only then we reduce the plane of anesthesia. So if you see the recovery of the patient, you don't need to do anything during at the recovery. The patient will just wake up at the end of the surgery. So that is the advantage you have when you are using this mask technique. But as I said, if you are not used to this, it is always better to put in an LMA. Even for bigger patients, obese patients, I would put an LMA rather than doing them on mask. So obese patients or some 11-year-old who say 50 kgs, that in such patients, I would prefer to putting an IGL or whatever LMA you like rather than doing it on a mask.
Thank you, Ankit.
Yes.
Any questions from fellows? And then we can move to the quiz. Sangamitra.
Just one sec, sir.
Can any of the fellows, I don't know whether I've missed it, but can any of the fellows tell me how do you assess pain in pediatric patients? Which is the scale you use? Am I audible?
And we can use the visual analog score, or in pediatric patients, we use the uh, facial um,
A draw.
um, I mean, if the patient is in pain, the crying a lot, or if the patient is sleeping peacefully post the procedure. I forgot the.
Neeta ma'am, you
Madam,
are
you are on mute.
muted.
Neeta, madam, you are on mute.
Sorry. I said in adults, when do you treat pain? When the VAS score is how much? In adults, when you plan your studies, when do you treat the pain?
When we have a VAS score of more than 4.
Anyone else? Dr. Kapil was raising his hand.
Ma'am, even I was
Anyone
going to
else?
say more than 4.
Ideally, you're not supposed to allow them to bear anything more than 3. 3 or more rescue has to be given. So if you tell me if the child is crying, it's very arbitrary, isn't it? So how do you decide on when do you need to give a rescue in a child? Have you given any rescue blocks in pediatrics?
Haven't yet. I haven't.
Okay, this is just a thought. Second point, what I would like to know is, I don't know whether I've missed it. There was one image wherein I think it was the lateral infraclavicular, it was the infraclavicular block. The ergonomics was way beyond understanding. It was the needle was pointed, the person was giving it in a very weird angle. So can you tell me the ergonomics if you're giving an infraclavicular block? How would you position? Where would you stand?
Ma'am, I would stand at the head end of the patient, and depending on the side, I'll keep the machine on the same side of the block that I'm giving right in front of me.
And the direction of the needle?
Cranial to caudal.
So just go through your slides. I don't know whether it was yours. I think it was in one of the images. It was not a proper ergonomics for sure. Second thing is, what is the concentration of the drug that you use for the block in pediatrics you mentioned?
0.25% of bupivacaine.
So are all children, I'm specifically talking about the age group of 2 to 6 years. Are they happy with this 0.225 or you've had issues? Does the child complain?
Not that I have come across, ma'am.
So a very heavy block. I've had 2 or 3 children complaining of my hand. I have lost my hand, bring it back.
Okay.
So it's beneficial. Anyways, you're not giving it as a sole surgical anesthesia. It's wiser to use as an analgesic dose, at least the movement should be there. So 0.2 is much better than using a concentration of more than 0.25.
Okay.
Okay,
I
just
think,
for
I think,
longevity of
madam,
the block.
I
So
would beg to
if you
differ
asked
from
about how do
this.
you prolong a block,
Madam, I would
yes,
beg to
please tell me.
differ from this. We would always, like as an institute, we always prefer to give complete anesthesia in all pediatric cases. So because the way we handle the airway, we keep them on mask with very low doses. As I explained, we want the cases to be done under regional anesthesia with sedation. So most of the cases we
But
do use, yeah. So that is our practice, madam.
most of your cases
And
you mentioned using lignocaine, right? So lignocaine is a shorter acting. I'm talking about post-op analgesia. Try not to use very doses which will cause motor blockage for post-op analgesia. So when you speak about compartment syndrome and issues like that,
Yes, ma'am. When we place catheters,
that's
we
what
use
I said.
0.125%.
and sometimes
Yes.
what I feel is
So for post-op
if the
surgical anesthesia, if you're planning it, yeah.
so if the child is in
Suman.
the age of understanding where he can actually communicate to us that his hand is not being felt, I think preoperative counseling is very important part to communicate with the kid and to explain them that since this is going to be painful and you are doing something to give them relief and it is extremely transient. So I think preoperative counseling in the age where kids can actually understand, it's very important. Like rather than
Correct.
explaining parents what we are going to do, it is always better to communicate with the patient himself, because nowadays kids are, I know they are very smart and they will take your point very
Between
carefully.
the age group, between the age group of 2, it's very difficult to explain. Despite all this,
Yes,
it's really
yes.
heavy. I've had 2 or 3 kids, so very mindfully, if it's for analgesia, I use a lower concentration. And I completely agree if it's for surgical anesthesia, using lidocaine. Thank you.
So we can go ahead with the quiz now. Dr. Sangamitra.
Just a second, sir. I'm sharing. Am I audible, sir? Hello?
Yes, yes, you are.
Okay, sir. Okay, 1 second.
Sangamitra, if it is not working, we can skip it today, as it is already 8:30.
So just 1 minute, sir. Just 1 minute.
Okay, then.
Is it visible, sir?
Not yet.
Okay, sir.
We can see the screen now started. Now started.
Okay. So We are starting with the Kahoot quiz. So I'm sharing the pin. Please scan and join. In case you have any issues with joining, go to your WhatsApp chat of West Zone. There I have shared the link also. Fellows are requested to join. If possible, please use your full name so that we can know who the winner is.
Recording in progress.
Any person wants to join? So most of you have got the correct answer. Actually, all of the above could be the actual answer here. Yeah, I will share an article which discusses this stoplight sign. It's an RAPM article. It will help you. Dr. Kapil is leading. Dr. Antara has discussed this. Again, Dr. Kapil is leading. A bit difficult one. Correct. Remember, it's about median nerve. Faster. I think this one easier. I think this is a controversial question. I took the levels from the ASRA and ESRA guidelines. I will just forward you the article. Hmm. We are on the last one.
Who is A?
Who is A?
It's me, Antra.
Very good answer. Well done.
Thank you, sir.
And well done to all the fellows who participated in quiz. They are little difficult question because most of must have read about upper limb blocks rather than
Yes.
reading pediatric anesthesia. So you attempted well, all of you. Ankit,
Yeah, it's a good session. Antra, the presentation was good. I think uh, pediatrics, you have to just remember that pediatrics, all blocks can be given. must just take care of the safety of the patient and try and do type A blocks before you go on to mastering the other blocks. So first master your auxiliary block before you go on to the other blocks. Uh, I think it was a good session today. If there's any doubts, I think you can ask on the group. The group is always there. We'll be happy to answer all your queries on the group also. I think Kiran can conclude the session. Kiran, can you conclude the session?